Welcome to today's webinar at ET Health World. Today we have with us Professor Vikram Patel, who is the co-director of Center for Control of Chronic Conditions at Public Health Foundation of India. He is also a professor of international mental health at London School of Hygiene and Tropical Medicine. In the year 1996, he founded the mental health research NGO named Sangat in Goa. Times magazine has recently listed him amongst the 100 most influential people in the world and also described him as a well-being warrior.
Okay, well, thank you very much, Rai, for inviting me here today, and good afternoon to all my listeners out on the internet. My talk today is about suicide in India, why India's public response is completely wrong. In fact, I could have titled this particular talk, Suicide in India, the Mockery of Science. The title of the ET webinar is suicide likely to become the #1 killer in India? I will definitely answer that question as we proceed this afternoon. Now, suicide has been on the front page of our newspapers for quite a few years now. Way back in 2006, the Lawyers Collective journal had produced this cover story, "What is driving our farmers to suicide?" In fact, I don't think any one of us is unaware that farmer suicide attracts such a great deal of media attention around the country. In fact, there are very few health issues that can be the make or break clause in elections as much as suicide of farmers has been. And generally, the idea has been that it is the mismanagement of the agri-economy that has been primarily responsible for farmers' suicide. The debate about suicides in India and the government's role or lack of effective role every year recurs when the National Crime Research Records Bureau produces its annual report on accidental deaths and suicides. Now, for those of you who don't know what the NCRB actually does to produce these reports, it essentially collects data from police stations around the country on all injury-related deaths, that includes accidents, homicides and suicides, and then collates them in an annual report that gives you an idea of the numbers of each of these events that occur around the country, and also breaks them down by gender and by state and by age. Typically every year when this report is released, we see a flurry of news reports really documenting these different statistics, and following this, a flurry of allegations and counter-allegations by various political parties and other civil society groups on what these statistics actually mean in terms of the government's action or inaction. There was this particular report in 2014 was no exception. Its release a couple of months ago has been heralded by a whole range of reactions in the government, and this is reflected in the sorts of stories that we have seen in the media. In the next few slides, I'm going to show you a snippet of some of those stories. So here is one story from the Hindu newspaper, which reported one particular finding of the NCRB 2014 statistics, which was that more housewives were reported to have committed suicide in 2014 as compared to previous years. The India Today reported the hapless minister's account that drugs, love affairs and impotency were behind farmer suicides. Now, in this particular case, the minister had derived his source of information from a particular section of the NCRB volume that looked at the reasons that surviving members of the family had told the police were responsible for the suicide. And he was simply quoting from that report, and of course, as you can well imagine, this attracted a furious reaction from other parties that the government was distracting from the more fundamental problem that you can see in fact displayed on this particular news story of the drought. And instead of dealing with the effect of the drought, they were distracting and focusing on trivialities like drugs and love affairs. Indeed, the issue of farmer suicides has always been in our forefront when we've thought about suicide. So the Indian Express, for example, carried this part, or this particular interpretation of the NCRB data, where it turns out that not a single farmer suicide occurred in the state of Rajasthan in 2014. In fact, more generally, the NCRB data showed a decline in the number of farmer suicides in the last few years. Now, it's this decline which aroused a counter response from civil society. In this particular piece by the celebrated journalist Mr. Sainath, who has documented the issue of rural livelihoods and deprivations for more than a decade, he commented on whether in fact the NCRB statistics could be trusted. He challenged this apparent decline of India's farm suicides and questioned whether in fact the recording of occupational categories was being fudged, basically. He was alleging that people who were farmers and had committed suicide were simply being reclassified as some other kind of occupation. Similarly, some people have argued that housewives is a misnomer because many women who work at home also work in the fields and they could also be farmers. In other words, a large number of people, according to these critics, who have been classified in other categories of occupations are actually farmers, and this is the reason why it looks like the number of farmer suicides has reduced in the last few years. Now, the question of whether or not the NCRB data are reliable and should therefore lead to such a vigorous national debate is of course something the NCRB itself disclaims itself from. This particular slide in fact takes out, is directly from the NCRB report, and I want to really focus on the lines that have been highlighted here. It tells us that the data reported in these annual reports are actually derived from police recorded data, and as it says later on in the paragraph, the NCRB itself will take no responsibility for the authenticity of this information. Now, considering the fact that, first of all, injury-related deaths, and particularly when you have to classify them as homicide or suicide, if you just consider the implications of this in terms of how the police might actually classify death as an accident, injury, or homicide, also how variable police performance might be across states of India, you can begin to see that these data may potentially be full of holes. So here is the real curious situation we have. A fundamentally flawed data source, which even its owners disclaim, has become the basis for a furious national debate on who commits suicide and why, with bitter divisions defined by ideologies, with actions that are proposed targeting only one group of Indians, that are farmers. And as I will show you later, while for more than a decade India has convulsed every year about how to deal with suicides, the rate of suicide has not changed one little bit in the last decade. So all of this argument and debate and discourse has not saved a single life. Instead, what we do know from epidemiology, the science of medicine, which has provided robust answers across populations both in India and abroad, and from countries around the world, we now know so much about the causes of suicide and how these can actually be reduced. This evidence from epidemiology is totally ignored. Now, for those of you who are clinicians, or those of you who may not be in the business of medicine, I thought it would be useful for me to just quickly remind you of what epidemiological science is. Epidemiology is essentially the science that studies the patterns, causes and effects of health and disease conditions. So for example, what is the prevalence of a particular condition and why does it occur in a particular group of people? It is also very important cornerstone of public health because by understanding the distribution and the causes of disease, it helps us define what might be the policy decisions and clinical interventions which can help both prevent disease as well as treat disease. So this is epidemiology, the definition of epidemiology, and as I'm sure you realize, this is really the foundational science for clinical medicine and public health. So what does epidemiology tell us about suicide? Well, it tells us many things about this condition that are very important for policy action. First of all, it tells us how much suicide happens in our country, who suicide affects and where does it occur. It tells us about the causes of suicidal behavior, and in particular, it helps us examine the links with farming. And finally, it tells us about the solutions for suicide, both in terms of political interventions all the way through to public health and clinical interventions. Now, I'm going to start really with my evidence by drawing upon the only national study of suicide mortality in India, the only study that has been actually carried out by directly asking households in which a death has occurred about the cause of the death rather than relying on police statistics. And that is the Million Deaths Study. This particular paper that appeared in the Lancet Medical Journal was the first publication of a nationally representative study of suicide mortality in India. Let me tell you a little bit about the methodology of the study. Well, first of all, the data comes from the Registrar General of India. So it is actually a Government of India study. The Registrar General carries out a nationally representative sample of 6,671 small areas that are randomly chosen from around India. As you can see on this particular map of India, the dots really represent the small areas that were randomly selected. And in each area, there are about 1,000 people. The Registrar General of India has an army of field survey enumerators who will visit these households every few months, will inquire about all deaths that have occurred in that household, irrespective of the cause of the death, and will then carry out a verbal autopsy, which will then be shared with a physician, in fact 2 physicians, who independently will use that verbal autopsy to code the cause of death. Now, this particular methodology clearly is very different from the NCRB numbers, obviously because the NCRB numbers are based on what the police interpret the cause of death rather than a physician interpreting the cause of death using a verbal autopsy. You should also keep in mind that in the case of police reported statistics, we have a further source of bias, which is the fact that suicide was a crime in India until earlier this year. In other words, if someone had died from suicide, the chances that a family would report the behavior as being related to a suicide are quite slim. And thirdly, the Million Deaths Study provides direct suicide estimates from a nationally representative sample. So what does the Million Deaths Study tell us about the burden of suicide in the year 2010? Nearly 2 lakh Indians, about 2/3 of whom were men, ended their life at their own hands in the year 2010. Put another way, about 3% of all deaths in Indians aged 15 and above were due to suicide. In contrast to the 2010 statistics for suicide as reported by the National Crime Record Bureau, the Million Deaths Study shows that the NCRB underestimates suicide in men and women by between 1/4 to 1/3. In other words, 1/3 of all suicides in women are being misclassified, usually as accidents. And this underreporting is even greater for young women and to a lesser extent for older women. Now, in the case of younger women, there is a very good reason for this, and this is that under our law, if a woman commits suicide within 7 years of marriage, the police are required to file a FIR against the woman's spouse and his family and to investigate whether there was a case for abetment of suicide. So as you can again imagine, there is a great incentive for families to have the death reclassified as perhaps an accident in order to avoid any further police investigation. And that might be one reason why the NCRB systematically undercounts these suicides. Now, what does the Million Death Study tell us about suicide by different regions? And here you see some very interesting differences emerge. I want to just draw your attention to the figures in the brackets, because those are the actual suicide death rates. Now, what you can see here is in both males and females, rural suicide rates are much higher than urban rates. In the case of men, it is 3 times higher, and in the case of women, it is 2 times higher. Now, there are good reasons for this. The most likely reason is that more lethal methods of suicide, like pesticide poisoning, are much easier to access in rural areas. Another reason is that emergency medical care for such serious attempts are much more accessible in urban areas, and therefore people are more likely to survive a serious suicide attempt in an urban area. But another very interesting difference is the geographic difference, the south versus the rest of India. It turns out that the rates of suicide in the richer and more developed states of South India are much higher than those of the rest of India. Now, when the NCRB produces this map that shows the suicide rates across the country, typically people are surprised. Why are they surprised? They're surprised because the poorest states of India, like Uttar Pradesh and Bihar, are shown to have extremely low suicide rates, whereas the richest states of India, which otherwise show much better health and social indicators, like Tamil Nadu and Kerala, have the highest suicide rates. Now, typically, most people look at the NCRB data and they say, well, you just can't trust the Bihar police. The problem is that the reporting of suicides in Bihar is likely to be inaccurate because the system in Bihar is not as reliable. Actually, that's not necessarily true, because the Million Death Study, which, as you remember, is a community-based study, it does not go through the police, in fact replicates the NCRB data. It may not count the same number of suicides, but there is a definite replication of the distribution of suicides. As you can see from the Million Death Study findings here, for both men and for women, the epicenter of suicides in India are southern and western India. Now, this is a very curious finding. Curious because the southern states are the richer and most socially developed states. And I'll return to this point about why this might be the case a little later in my talk. In fact, this difference is nearly tenfold. The suicide rate in Tamil Nadu is 10 times higher than that of Bihar. Keep that in your mind, because we'll return to that when we start thinking about links with farming and other factors. Now, another very important finding of the NCRB and replicated in the Million Death Study is that suicide in India is primarily a young person's problem. On this slide, you can see the suicide death rates for men in India as well as in high-income countries. The Indian line is the blue line. If you look across the ages, you will see that the suicide rate in India, in Indian men, is only slightly higher than that in men in high-income countries. You can see the average rates at the bottom of the chart. However, if you look at young Indian men, you will see a much larger gap appearing. That is to say, the suicide rates in young Indian men, for example, aged between 20 and 24, are 2 to 3 times higher than in rich countries such as in Western Europe. Let's look at what happens in women, and you will see immediately as you see this slide that the gap is even more dramatic. First of all, if you look across the ages, you will notice that the suicide rate in Indian women across the ages is 3 times higher than that in high-income countries. But if you look at young Indian women, aged between 20 and 24, that is a 6-fold difference. Think about that. Young Indian women are 6 times more likely to kill themselves than, say, for example, a comparable aged woman in Europe. We need to ask questions why that is the case. Indeed, suicide now is one of the leading causes of death in young Indians. The title of this webinar was, "Is suicide likely to be the leading cause of death in India?" No, it will never be the leading cause of death in India, but it certainly is the leading cause of death in young Indians. As you can see in this slide, suicide in 2010 was the second leading cause of death in young Indians aged between 15 and 29 in both men and women. And if you consider that maternal conditions are likely to keep falling, and indeed have fallen substantially since 2010, whereas there has been no change at all in suicide rates, it is highly probable that suicide today is already the leading cause of death in young women in our country. India would not be alone in this particular dubious distinction. Suicide is also the leading cause of death in young women in most other South Asian countries, including Nepal and Sri Lanka. Now let's look at the methods of suicide reported in the Million Death Study. Another very particular Asian pattern emerges here, something you will see across the Asian countries, and this is that poisoning through pesticides in particular are the leading causes of death, accounting for about half of all male suicides and about 44% of all female suicides. The pattern in Western countries tends to be quite different. For example, gunshot injuries are a very important cause of death. Really, this reflects the greater access to guns in the West and the greater access to pesticides in Asian countries that might explain the differences that you see in terms of the method used for suicide. So I want to now summarize some of the key findings about the burden before I move on to understanding the causes of suicide. The key findings from the Million Death Study show us, and also I think it has to be said, the NCRB data and the Million Death Study are very consistent with each other. The only real difference between the two is that the Million Death Study shows that the true number of suicides is significantly higher than what the NCRB reports. But if you leave the absolute numbers comparison aside, much of the other findings are similar in these two studies. Suicide rates in young Indians are amongst the highest in the world. Suicide rates for both genders are twice as high in rural areas than urban areas. 54% of female and 40% of all male suicide deaths occur before the age of 29. Suicide today in India kills twice as many people each year as HIV/AIDS, and now probably kills even more young women than maternal causes. Today in New Delhi, we have a major global conference on call to action to address maternal deaths. Most maternal deaths have occurred in young women aged below 29. I hope that one day we will see a call to action which will address reducing suicide deaths in young women, the leading cause of death in that group in our country. There's a tenfold variation across states in India, with the highest rates in the southern states of the country and with pockets of high rates in some other states like Sikkim and Northeast India. And poisoning through pesticides in particular is the leading method of suicide deaths. Now let's turn to the issue of why suicides occur. First of all, we must remember that completed suicide is only the tip of the iceberg. It is the result of a series of complex pathways between a suicide attempt and a death. So consider, for example, that in a rural area you might die from a suicide attempt because you chose a more poisonous substance or you didn't have good enough medical care. That is why your suicide mortality rate looks much higher than an urban area. In an urban area you might choose a less poisonous substance and you have better medical care. The true suicide attempt rate may in fact be higher in an urban area, but because of these other factors, the mortality rate is higher in a rural area. For us to really prevent suicide, we need to be thinking not only of the factors that lead to mortality, but we also need to be thinking about factors that lead to attempts. We need to recognize that the very large regional variations in the rates of suicide clearly point to a very important role of social factors that differ significantly between one part of India and the other. Because in doing so, we will then be able to point towards a more promising prevention and control strategies than the ones we have focused on so far. Now, what does the NCRB tell us about the causes that the police identified from family members who had survived a suicide? As you can see here, the largest chunk is other causes, a very mixed group of causes. But if we leave aside that mixed group and causes not known, the next biggest cause is family problems. This includes breakdown of marriage. This includes domestic violence. Marriage-related issues can be added to that. Together, that accounts for 25% of all suicides. The hapless minister reported love affairs. He was right, because in fact love affairs also is one of the causes. And then you've got illness and drug addiction, both of these of course, which include a substantial number of people with both physical as well as mental health problems. Now, we have been carrying out research on the factors associated with suicide, a number of different epidemiological studies carried out mostly in Goa with the NGO called Sangat. And this has been looking at the kind of risk factors for suicide in a variety of different groups, in young women, in young people more generally, and among sex workers. And I want to try and pull together all the knowledge into some simple high-level findings about the factors that are associated with suicide. First of all, we need to think of the social factors. In young women, the most important social factors are interpersonal difficulties, typically relationship problems with their male partners or with their parents, often linked to who they might be able to go out with, who they might be able to have romantic relationships with. Violence, both from their male partners as well as other family members, and educational stresses. In young men, slightly different pattern. Interpersonal difficulties again ranks as the most important factor. Education stresses, very important too. And income insecurity emerges as a particularly important factor for men. Typically, this is in the context of young men who have finished college and are then trying to find work, and the work isn't easy to find. Typically, those social factors are mediated through mental health problems. The most common mental health problems are depression and alcohol abuse. And for young people, we also need to consider two other very unique, relevant determinants. The first is the dynamic stage of development of adolescence and young adulthood. This is something we've only learned about and recognized in the last decade or so. Many of us often thought that the brain stopped developing after middle childhood. But today we know that actually the development of the brain continues well into adolescence and into young adulthood. And indeed there's something very peculiar that is happening in this age group. And that peculiarity is that the prefrontal part of the brain actually matures at a different time to the subcortical region of the brain. Essentially, that means that the part of the brain that is responsible for making informed decisions, for higher levels of judgment, actually matures later than the part of the brain that triggers impulsive action. And this is why in adolescence you will see higher levels of impulsivity and risk-taking behaviors than in other periods of life. One must also remember that in adolescence there's a lot going on. This is the stage in life when you're finishing education, you are trying to find a romantic partner, you're trying to find a job. And typically when you're trying to do so many really important things, you're likely to face disappointments more often than at any other stage in your life. When that happens, if you're an adolescent, you feel extremely low, and in an impulsive burst of feeling low, you do something very risky. You rush to your cabinet where the pesticides are stored alongside other household goods, and you take a swig. Of course, if you're in a rural area, that typically means that you're likely to die because there's no good medical care. So you can begin to see how this combination of the social expectations from adolescence during this phase of life, combined with the developmental stage that they're in, actually lends them to take more risky suicidal attempts than in any other stage of life. The other particular factor one must remember about young people in our country is the growing gap between the aspirations of young people and the social world they find themselves in. In particular, I want to take on this issue about the South India versus the rest of India. I've often been asked why this happens, and I can only speculate about this. And my speculation is this. Young women, for example, in South India are now achieving levels of education that are far greater than any other part of the country. With that education, with that exposure to the kinds of lives that young women have around the world, the aspirations of these young women are likely to now be quite different from those of their mothers and fathers. But unfortunately, the families that they come from and the larger society that they live in do not really permit those aspirations necessarily to be fulfilled. For example, an aspiration to be able to find one's own romantic partner. And I believe that this growing gap between the aspirations of young people and the social world that they live in may be one of the factors that is leading to greater degrees of despondency, despair, and misery, which then translates in an impulsive and risk-taking fashion to higher death rates due to suicide. Now, the big question, what about farmers? Well, what did the 2014 NCRB tell us? 4.3% of the total number of suicides that happened in India in the previous year were due to farmers. Now, of course, we all know that there's far more farmers than 4% of the population, and so clearly, if one believes this number, if anything, this would suggest that being a farmer is actually a protective factor. However, as many of the critics have pointed out, there is this real concern about the reliability of the NCRB data, and it is very possible that a very large number of people who have been classified as non-farmers are actually farmers. What is a true situation of farmers and suicides? Well, for this we return back to the Million Death Study, which, as you remember, is done from a community-based survey. What did we find? I'm going to read out from the Lancet article itself what was found. Suicide deaths in unemployed individuals and individuals in professions other than agricultural work. And here, by agricultural work, we included both landowning farmers as well as laborers who worked on other people's land, were collectively about 3 times greater than they were in agricultural workers. So it turns out that the Million Death Study findings are again consistent with the NCRB report, that if anything, non-farmers are actually more likely to kill themselves than farmers. And actually, this is also consistent with our observation that the rates of suicide are highest in young people in southern India who are highly educated and who are probably not engaged in farming at all. Another thing we need to bear in mind is that actually it isn't just in India that farmers are considered a high-risk group. So it is a global phenomenon. In fact, farmers have a horrifyingly high suicide rate around the world, including in Western countries. And this is due to many different reasons. For example, farmers have a very stoical attitude about their personalities and their lives. They're much less likely to seek help. They're much more likely to face uncertainty in their annual income because of their exposure to climate uncertainty. They're more likely to face uncertainty due to changes in commodity prices. This is not peculiar only to Indian farmers. Suicide rates in farmers are high due to a number of reasons. As this particular article reports, one of the main reasons is because of stigma and lack of education about depression as a major culprit in farmer suicides. I want to read out directly from this particular article here because I think it makes a really good point. Farmers tend to adhere to the stereotypical image of the self-reliant, tough farmer who doesn't complain. A farmer who complains of being depressed will usually be labeled as crazy, a whiner, or a wimp by fellow farmers. Instead of talking about his depression, a farmer might say, "I'm just tired or worn out." Ignoring or hiding your depression is not the way to deal with depression. And sadly, this has also been my own experience of working in Vidarbha with the farmers who are facing agrarian distress in that part of the country. So I want to now finish off by thinking in a positive way about developing and evaluating solutions for suicides in India that will include solutions for farmer suicides, but also for suicides affecting any other segment of our population. Now, I want to draw again to the importance of suicide as a political issue. One of the important findings of the NCRB was that Maharashtra had the greatest absolute number of suicides in the country. Of course, in terms of age standardized suicide rates, it wasn't the highest, but it was near the top. in response to which the Chief Minister of Maharashtra made a major announcement to make Maharashtra a zero suicide state. Of course, one of the ironies of this particular statement was that actually the government was planning only to focus on farmers, and even if farmer suicides accounted for 20% of the total suicides, it's impossible to see how a program targeting only 20% of the suicides can actually convert the state into a zero suicide state. But what's also more interesting was the majority of the government's programming was only in the form of financial incentives, part of which are paid if the farmer dies. Now, I was in Vidarbha last month and talked to some of the farmers about this particular system of compensating a family if the farmer dies, and they just mocked this particular program because they said this was like an incentive to suicide. If somebody actually faced an enormous household debt due to farming and they had no way of repaying this, one way that a farmer would actually try and secure a better future for their family was to kill themselves, because at least then the family would get money with which they could partly repay their debt. In fact, the government's policies on farming have produced no impact at all on the suicide rate in India. This is a table that shows the suicide rate over the last 5 years in India, and as you can see, almost no change at all in the last column. This is in spite of the very large amount of money that the government has spent to address agrarian distress. Not any impact at all. Instead, what should we be doing? We should be doing the sorts of things that other countries are doing. Other countries have done and dramatically changed suicide rates in their countries. The evidence on what works to reduce suicide and indeed to deal with a whole range of mental, neurological and substance use disorders has been summarized in this World Bank volume, which will be publicly released in the WHO on October the 8th in Geneva. In that volume, we have examined what are the key interventions for the prevention of suicide. And here they are listed on this slide. At the level of the whole population, we need to reduce access to pesticides and address social determinants, for example, being in debt. At the community level, we need to strengthen life skills training in schools and again continue addressing social determinants, particularly interpersonal determinants like domestic violence. And at the healthcare platform, we need to improve the management of depression and alcohol abuse in primary care, do better with the emergency management of poisoning in emergency rooms, and have a better system of following up suicide, abuse and survivors.
When countries do that, look what happens in China. China in 1987 had the highest suicide rate in the world, much higher than India. By a concerted combination of different actions, including promoting greater autonomy and gender rights for women, China has saved more than 1 million lives that would otherwise have been lost to suicide in the last 15-20 years. China today has a suicide rate much lower than India. Look what's happened in Sri Lanka. Sri Lanka had the highest suicide rate in the mid-90s, much higher than India, and indeed there was a presidential commission under President Bandaranaike, supported by the World Bank. And what did they do? They did just a couple of policy interventions of banning the most poisonous pesticides. And look how dramatic a fall there has been in the suicide rate by more than 50% just by a couple of high-level policy interventions. Unfortunately, what this particular study also shows us is that, yes, it's good that we've reduced the death rates, but we haven't actually reduced the suicide attempt rates. This analysis of suicide attempts showed that, in fact, during the same period that death rates fell, admission rates to hospital actually doubled. And this was because now Sri Lankans who were attempting suicide were now shifting to medicinal drugs. And so we need to bear in mind that controlling pesticides is a very immediate and a very effective way to reduce suicide mortality, but it will not necessarily reduce suicide attempt rates. And for that, what we need to be doing is we need to be improving access to mental health care by improving treatment for depression and substance use. I want to now end by just telling you a little bit about some of the work that we're doing to try and address some key barriers to address mental health problems. I think we need to acknowledge that there are two very important barriers in our country. The first is a demand-side barrier. and that is to do with the low levels of help seeking for mental health problems. Most people, as we saw in the news story earlier, do not see depression or alcohol abuse as a health problem, let alone a mental health problem, and so they typically would not consider going to a health facility to seek care. And even if they did go to a health facility, they are unlikely to meet a healthcare provider who has the skills to deliver the psychological and drug interventions that are needed for these conditions. The way to address these barriers is, first of all, to develop a program that uses a grassroots methodology, something that is actually grounded in the community and incorporates the sorts of concerns that communities have about their social determinants and about their mental health. And also to really maximize the use of community resources, because no community is without its own resources. So we need to really develop programs not from a top-down way, but from a bottom-up way, so that we harness the community's knowledge and the community's strength. And the second is to actually start using non-professional health practitioners, such as community health workers, peers, and lay counselors, in much the same way as we've seen happen in other areas of medicine. For example, in reproductive health and child health, the deployment of ASHA workers is a good example of how in our country we have some of the major innovations in using community-based workers to improve access to healthcare interventions. This is exactly the kind of approach we have been following for the last 4 years in Vidarbha region as a partnership between Sangat, PHFI, Water and Prakriti. Prakriti and Water are two local NGOs in that region which have been working on livelihood issues in those agricultural communities. The aim was really in a pilot area of 30 villages, 1 lakh population, to really establish a sustainable mental health program for addressing both the social determinants of suicide as well as addressing the mental health determinants of suicide in these communities. We were really using largely existing human resources, the existing community-based workers like ASHA workers, as well as existing primary healthcare center staff and the district mental health program staff. But in addition, with Tata Trust funding, we were also able to employ counselors who could be based both in the primary health center as well as in the villages. This is what the intervention framework actually looked like. At the community, counselors provided psychosocial interventions for depression and drinking problems, but also supporting people with more serious mental illnesses like schizophrenia. The community health worker did work on raising mental health literacy, providing referral, engaging the community. And at the top of the pyramid, at primary healthcare, you had psychiatric outpatient department clinics mainly focused on diagnosis and medicine treatment, and also the counselors would occasionally be based in those clinics when the psychiatrist was available. We're currently completing the impact assessment of this program, combining both process indicators, looking at, for example, how many individuals were identified with depression and sought care. We will be doing a survey in this population to look at what has been the change before and after the program in terms of mental health literacy and also the access to care, and also carrying out a case series of suicide survivors, families, and other beneficiaries. But there are many key achievements I want to finish by highlighting. Firstly, that we now have a comprehensive idea of what a rural mental health care plan should look like, with a full set of tools and deliverables that can be used by community-based workers, by counselors, and by primary care doctors. We know how these different human resources should work together in a collaborative way for service delivery. We know how there needs to be a partnership in a coordinated way between an organization that is working in the community, a technical resource agency, and the government. More importantly, at the level of the community, I'm delighted to see over the last 4 years in my regular visits to these village communities how there's been a transformation of community attitudes. Whereas 4 years ago, when we used the word mental health, typically members of the community would see this as being equivalent to madness and would bring out relatives with conditions like schizophrenia, intellectual disability, and epilepsy. Today, they have been able to shift their attitudes to acknowledge distress in the form of drinking problems, domestic violence, depression, and anxiety as also being part and parcel of the larger domain of mental health. And finally, that there's been active community mobilization on the right to mental health. And I think the best evidence that we have for this has been that Of the 30 villages, more than 20 panchayats have had Gram Sabha resolutions to the government of Maharashtra demanding the sustaining of the mental health care program beyond the project period. In conclusion, here is what the science of suicide prevention tells us, and this is what the government should be actually acting on. Suicide is a leading cause of ill health and death in India, especially in youth. It is already the leading cause of death in young Indians. Farmers are a high-risk occupational group in all countries, and there is no difference really, as far as I can see, of farmers in India from farmers in other countries. Programs that address suicide should address farmers, but address others in the population as well. We need to address both the distal and proximal social determinants leading to mental health problems, for these are the key to understanding the origins of suicidal behavior. And to do that, what we need is an integrated, community-based approach that combines a range of evidence-based strategies, working at the whole population level, working at the community level, and working at the individual clinical care level, if we are ever going to be able to tackle the prevention and treatment of suicide and suicide risk factors in India. Indeed, we must draw inspiration from countries like China, Sri Lanka, and many other countries around the world that have shown that if you apply science to the task of suicide prevention, you can dramatically reduce the burden of suicides in those countries. I'll stop there and hope that we can now take some questions from the audience. Share the questions, you can see the questions. Okay, so let me take the first question from Ehab Ashraf, which is, has epidemiology been used by the police while recording the data? Well, not really. How does it actually work? In the case of the police, typically there will be a suspicious death. Typically that's an injury-related death, for example, a poisoning death or a death because of a wound. The police will then have an inquiry with the family, and then the coroner will pass a judgment based on that inquiry about whether the death was an accident, a suicide, or a homicide. Obviously, if it's a suicide or a homicide, there needs to be further investigation, although now with suicide having been decriminalized, what I suspect we're going to see in the years ahead is a larger number of deaths being attributed to suicide. So if we do see, for example, next year, an increase in the suicide death rate, one mustn't quickly jump to the conclusion that this is because of a true increase. It could well be because having decriminalized suicide, coroners and police are actually finding more families, providing more information that allows them to acknowledge that the death occurred due to a suicide. It's certainly not epidemiology in the way that we understand that in public health. Right, let me now turn to the next question from Suchi Kapoor. Suchi's asked the question, what is the source of the statistics about suicide? I guess I've kind of answered that question already in response to Ehab's question. But again, just to say there are two different sources that we have in this webinar. The first is the NCRB source, which I've already described what its origins are. The other is that I've drawn on heavily is the Million Death Study. The Million Death Study is a study that was commissioned by the Registrar General of India. And really what it does is it surveys all causes of death in pre-selected households in small, randomly selected small areas around the country in regular surveys. So it has field workers who go to those houses and ask family members about, the head of the household typically, about all deaths that have occurred at any age, and then does a verbal autopsy using a standardized form, and then that account is rated by two physicians who then accord a cause of death. And if there's a discrepancy between the two, then a third physician is called in to adjudicate. So it's the most reliable method we have. It's not 100% reliable because you can well imagine that if someone ended their life due to suicide, the survivor in the family may also give a slightly untrue account in certain situations. And so it's very important for the account to be very carefully documented, and then for the physicians to be well trained to be able to really pick up discrepancies in the account, which will then enable them to more accurately classify the death as suicide. Okay, let me turn to the third question. The next question here is from Pradnesh Desai. The question is, preventing suicide, should it be the government's role or the community? That's a good question, really. In my view, it's not either or, it should be both. I think for all health issues, both the community plays a role. Indeed, I think the individual also plays a role in managing their own health. The community plays a very important role in managing the sorts of determinants that work at community level. For example, let's take, for example, something like communal violence and marginalization of certain groups in the community. Let's take, for example, gender-based violence, any form of violence, really. The community plays a very important role in making this an unacceptable form of behavior. And of course, the government plays a key role in ensuring that it sees suicide as a public health issue. It's very important for all the political parties to come together around this. If there was a genuine desire to reduce farmer suicides, then I think there are solutions out there. People have shown how this can be done. We don't need to be struggling with figuring out how to do it. We should simply be using the lessons drawn from our neighbors, China and Sri Lanka as an example, and start implementing some of those solutions. There's no doubt that some of those solutions may need to be very local, but I don't believe that we can't learn from other people in other countries on how they have managed to successfully reduce suicides, both in farmers as well as in non-farming communities. So really, in answer to your question, I think suicide is everyone's responsibility because mental health is everyone's responsibility. It's too important to be left to any one sector alone. We all must take responsibility for our own mental health and that of the people who we live with. Okay, the next question is from Rajiv Chipper, and here the question is, there have been reports in the Western media linking suicide to genetic factors. And then, since India is the leading country globally in suicide, does it mean we inherited them, or was it some kind of reason for social determinants like caste, religion, sex, creed, and so on? Again, that's a great question. I guess, like almost every health problem that I can think of, certainly in the mental health field, genetics does play a role. But also, like almost every health problem in the mental health field, social determinants play a very profound role. So I think my straight answer to that is yes, there is likely to be an interaction between genetic vulnerability and social stresses that ultimately lead to suicidal behaviors. For example, you have to ask yourself the question, let's say out of 100 women who live with a violent spouse, only about 15 or 20 would develop depression. Why is that the case? Clearly, there might be other factors that need to be brought into our understanding of the causation of depression. It's not just simply the violence, but some other factors. There could be access to protective factors like helping persons in one's immediate social networks. It could be some genetic vulnerability. It could be something to do with one's childhood experiences. But clearly, it's more than just the violence. And in that other factor group, genetic factors must play a role. Similarly, of the 20 or 30 women who become depressed, only 2 or 3 will attempt suicide. And again, you have to ask yourself a question, why is it that only 2 or 3 of the 20 or 30 depressed women commit suicide? And again, it has to be due to interaction between the social determinants and a number of other factors that might be interfering with the woman's ability to address those social determinants. I can't see any more. Yes, there are quite a few. Yes, sorry, I didn't see there was a, I'm sorry, I didn't realize that. Okay, Karthik has asked the question, has anxiety also proved to be a serious reason for suicide in youth? What treatment do you suggest for it? Yes, I think that's a good question, Karthik. Anxiety and depression are two sides of the same coin. Just as much as depression is associated with suicide, so is anxiety because it frequently co-occurs with depression. I don't think anxiety standing alone in itself is a very major factor. Of all the mental health factors, I would have thought depression and alcohol abuse is very important. But anxiety co-occurs also with alcohol abuse, and it may therefore, through that route, be an important factor which then predicts suicide. I know that certain kinds of anxiety like panic attacks and phobias can make people extremely depressed, and because, for example, it comes in the way of them engaging in social spaces, and that may therefore then lead to depression and then ultimately to suicide. Dr. Danish Ahmad has asked a question. Thank you. I wanted to focus your attention on suicide rates among young adults and interventions that can be introduced much earlier in life. Could you please, I can't see the rest of the question. Could you please, maybe your question is, could you please give some opinion about this? Danish, actually, I think the most effective interventions for young people are life skills training. Now, in our country, we have something called the Adolescence Education Program that is being rolled out, but unfortunately, it's primarily focusing on 9th standard students. I think that's a little too late. I think we should be having life skills being taught right from primary school, obviously developmentally appropriate because you need to actually tailor the kind of content of the curriculum according to the age of the child. But it seems to me addressing issues like sexuality, about conflict resolution, about bullying and violence, about inclusion and exclusion, etc., are issues that must be taught as early as possible. I also think that one should do a lot to change school environments. In fact, we have a big program going on, a randomized control trial, in fact, in Bihar right now, which is seeking to alter the school environment in secondary schools, in government schools in Bihar. And our goal is to show that if we can change the school environment, such as the kind of connectedness that students have with each other and with their teachers, that we can show benefits to their overall health and also more specifically to their mental health. Let me go to the next question. This is from Daniela. You spoke about implementing life skills training and the possibility to prevent suicide and mental illness in young people. According to your view, what is the effectiveness of life skills training in the long run? Again, I can't see the rest of the question, so I'll just answer that. I think that's another great question, Daniela. Unfortunately, the way research funding is that we typically expect you to finish our outcome assessments at the most within 3 to 4 years after we've begun the trials. And the question you're asking is about following these young people up much later into adult life, when we can begin to look at the impact of the sorts of life skills training they had in school on adult health outcomes. I actually genuinely don't know of any trial that has successfully been able to follow up people for that long. And so I would say the evidence is still out there to be made. My hypothesis is that good life skills training does in fact promote mental health and indeed promotes a number of other social outcomes in adult life, which I think are uncalculated, unestimated benefits of life skill training in school. The next is from Pravati. What is the difference of suicide rate amongst educated and uneducated? Stress comes from low income or from high income? Yes, that's a great question. Actually, one of the more interesting findings about suicide in India, which makes it quite different from Western countries, there's so many differences. For example, the high rates of suicide in young people, the fact that in young people, women and male and female suicide rates are the same. The fact that mental illness accounts for only about 50 to 60% of suicides and not 90% as you see in the West. One of the other differences is that actually suicide rates in India tend to be either neutral when it comes to educational class or in fact tend to be more common in the more educated. In the West, you will see an opposite pattern. You will see suicide rates commoner in the less educated. And I think that is again a very important difference. One of the reasons I speculated in my talk was that this reflects the aspirational gap. Those who are more educated have greater aspirations, and when you have more aspirations, you therefore have a more likelihood of being disappointed when the reality that your life has for you is going to be much more likely to be much more different than your aspirations. So it's speculation. I can't say that I've done any empirical research on this, but it's speculation that might be a reason why suicide rates are higher in more educated Indians. Opportunities simply don't meet up with their aspirations. Shruti's question, what barriers do you see for a national level suicide prevention program? I asked this question at a meeting in Vidarbha last month to some colleagues, and I said, why is it that we cannot talk about mental health when it comes to suicide? And one of my colleagues who's very close with the Maharashtra government said, because it's a political suicide. The moment any government starts talking about mental health, immediately all the opposition parties will pounce on them, and also some of our civil society activists saying that you are distracting from your failures and talking now about mental health. This is the tragedy of political discourse in our country in many areas. Rather than relying on science, we are taking cheap political pot shots while people are dying. And I think suicide is just one example, but perhaps the most poignant example where we've allowed people to die on the altar of political correctness. And I think it's time for all the political parties to come together and recognize that saving lives is more important than taking political pot shots. And I think we shall take the last question now. Amelia's question, is the million death study still ongoing? Yes, it is. It's a continuing study. I'm afraid I can't tell you when the government of India will produce its latest round of data. It belongs to the Registrar General of India, but I'm very much hopeful that we get those data as soon as possible, so we get, once again, more accurate data on not just suicide, but also all other causes of death in our country. I think we've hit the 4 o'clock barrier now, and so I'll say thanks to all of you for joining this webinar and for the wonderful questions that you sent me, and I hope you've enjoyed this afternoon with me.